session, and that will be featuring on SGLT-2 inhibitors across the spectrum of heart failure, veni, vidi and vici. We have Professor Aditya Kapoor, Head Department of Cardiology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Deliberate for the next 12 minutes. Professor Kapoor, please.
Thank you, Professor Kapoor, for agreeing to present this talk. I think we will be, Professor Kapoor came, Professor Kapoor delivered, and Professor Kapoor conquered. That is what I am waiting for.
No, sir, thank you so much for the kind words. So the spectrum of heart failure, if you look at the universal definition today, we all know that reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction has been recategorized now, and of course we have a new category, improved ejection fraction, due to the trajectory change in EF which can happen with therapy. Each hospitalization of heart failure is associated with bad outcomes, so we need to worry about that. We'll cover these issues as we go along. And since SGLT-2 inhibitors were primarily came in as anti-diabetic agents, we should understand the concept of residual vascular risk. Despite intensive glycemic control in diabetes, if you look at the heart failure MACE and MI risk, the percentage risk removed is 0, 9 and 15. What does this mean? This means that despite the best of the glycemic control, only 9% of the MACE, 15% of the MI risk is removed, and heart failure risk is not affected at all. So we need to do something about that. That is why the SGLT-2 inhibitor story started. The EMPA-REG outcome trial, which was diabetics at high cardiovascular risk, it showed a remarkable reduction in endpoints. And when they teased out the data for heart failure versus no heart failure, they found the risk benefit was the same. More remarkably, the benefit was very early, 38% reduction in death, CV death, within about a month or so. And when they again analyzed this data in terms of the temporal benefit, in the first 360 days, the time to CV death, the maximum benefit appeared by about 60 days. Time to first heart failure hospitalization, the benefit appeared by about 3 weeks. And first heart failure hospitalization or CV death, the benefit appeared as early by 4 weeks. So not only was the drug effective, it acted very early. Large benefit with SGLT-2 inhibitors in terms of reduction of heart failure hospitalization in all major CVOT trials, be it the EMPA, the CANVAS program or the DECLARE, nearly 35% reduction in heart failure hospitalization. So the unexpected story which started with EMPA-REG was duplicated by the DECLARE trial. Both the drugs added to the safety data, and people started wondering, this strong signal for preventing heart failure can be extended to the entire spectrum of heart failure as therapeutic agents. So the story started from EMPA reduced and Dappa Hf. We'll just discuss 4 points in terms of each trial. The EMPA reduced, median follow-up of 16 months, heart failure patients, half were diabetic. And what they found was that CV death, heart failure hospitalization reduced, recurrent heart failure hospitalizations reduced, renal outcomes also reduced. Clinical benefit appeared again very early as day 12. Benefited across subgroups, diabetic, no diabetes, young versus old, irrespective of ARNI use or mineralocorticoid receptor antagonist use. And no safety signals, it had no major safety issues in diabetes or no diabetes. The Dappa Hf trial, again similar patient population of heart failure, median follow-up 18 months, half were diabetic. It showed worsening heart failure or CV death reduced by 26%, heart failure hospitalization reduced by 30%, and very remarkably, CV death and all-cause mortality also reduced in the Dappa Hf trial. Again, similar to EMPA, curves separated rapidly. The benefit appeared very early after treatment, as early as 1 month. So again, the drug was effective, acted early. Subgroup analysis for the Dappa Hf, young versus old, similar benefit. NYHA class biomarker, it was effective across all subgroups, and diabetes versus no diabetes, similar effect. No major safety outcomes. But when we look at the Dappa Hf and the EMPA reduced from a more analytical point of view, although CV death, heart failure hospitalization reduced similarly, only Dappa Hf showed reduction in CV death and all-cause mortality, and renal outcomes were better reduced in the EMPA trial. However, this is just because the patient populations were a bit different. If you look at the EMPA reduced trial, the ejection fraction was a bit worse, biomarkers were more high, eGFR was lesser, and more patients were treated with ARNI. So it was a sicker patient population, and probably this is a class effect. And the slight difference in the two trials is related to the heterogeneous patient population in the two trials. So that is why when they combined the data sets of the EMPA reduced and the Dappa HF, they found that all-cause death, CV death was reduced, and first heart failure hospitalization and renal outcomes were also reduced. And this benefit of both the drugs was irrespective of the fact whether or not there was diabetes. So the carry-home message in systolic heart failure, both SGLT-2 inhibitors were robustly effective regardless of the presence or absence of diabetes. So that is one important carry-home message. Post these two trials, what is the place of these drugs in heart failure reduced ejection fraction? So diabetics, non-diabetics, it will work. Older, younger patients, it will work. Work across the spectrum of low ejection fraction. Two more important points. Is it ever too late to start these drugs? Adding it on top of guideline-directed medical therapy. So points D and E, the Dappa HF sub-analysis found that if we assume in clinical practice that patients of long-standing chronic heart failure are stable and they may have little to gain to add more drugs, that is a therapeutic inertia. That is not true at all. In fact, these long-standing apparently stable heart failure patients are actually at higher risk, and they will get absolute more benefit if you add these potent drugs to these patients. So you should not shy away from adding these drugs in seemingly stable chronic heart failure patients. Never too late to start treatment. Polypharmacy we always shy away from in heart failure because we feel there will be adverse outcomes. However, data has shown that you can combine these with mineralocorticoid receptor antagonists, and in fact adding them or preceding SGLT-2 inhibitor prior to MRAs is not a bad strategy, and of course you can combine them in these patients as well. Combining them with ARNI beta blockers, that is all four therapies, excellent data published in Lancet. If you add this in a patient of age 55, 4-drug therapy will add 6.3 additional life years. In an older patient, it will give you still a 4.5-year additional benefit if you add all these drugs. So it is a good drug to have, and you should always consider it in your therapeutic armamentarium. Lastly, coming quickly to preserved ejection fraction, this is recent data. Of course, we all know that even in India, if you look at the burden of heart failure, preserved ejection fraction, it is considerable, and these patients often do badly, so one needs to worry about them as well. And the Emperor preserved, we all know now that in these patients who were diabetics, non-diabetic, both patient groups were there. Heart failure, preserved ejection fraction, EMPA compared to placebo was tested, and in this trial about 1/3 patients had ejection fraction from 40 to 50, 50 to 60 and more than 60. About 2/3 were non-ischemic heart failure, and they were pretty well treated with guideline-directed medical therapy. And when they look at the trial results, CV death or heart failure hospitalization was reduced by 21%, recurrent heart failure hospitalization was reduced by 27%, and renal outcomes were also better. Again, very early benefits from as early as day 18. Subgroup analysis worked in both genders, irrespective of diabetes, irrespective of renal function. Very elegantly they studied that in heart failure, mid-range ejection fraction versus ejection fraction more than 50%, similar benefit, in fact the maximum benefit was in the patient group of around 40 to 50%. No major safety issues in the Emperor preserved, and the messages was that even in heart failure preserved ejection fraction, the benefit was impressive, benefited across the ejection fraction range, although the benefit got attenuated at ejection fraction more than 60%. Both genders benefited, and there was a non-significant 9% directional benefit in mortality. So this is the first study in heart failure preserved ejection fraction to meet its primary endpoint, and that is why it's now recently been approved. And when they pooled the data from all the EMPA trials, they found that if you group by ejection fraction, remarkably 25 to 30% reduction with EMPA across the entire range of ejection fraction. Only, as I mentioned, in people who had EF more than 60, 65, the benefit got attenuated. So this is one of the last few slides. If you look at heart failure, reduced ejection fraction and mid-range ejection fraction, the drug works very well, and now data suggests that even preserved ejection fraction, it has a significant benefit. Lastly, quickly coming to acute decompensated heart failure, this is a recent Impulse trial in which people who were admitted to the hospital with acute decompensated heart failure, within 3 days they randomized them to either EMPA versus placebo. And this was a stabilization criteria that the guy had to have a stable blood pressure, no increase in IV diuretics, not on vasodilators or IV inotropes, similar to the transition heart failure trial for the ARNI. And once the patient was stable enough, they found that these guys were 36% more likely to experience a clinical benefit when in-hospital EMPA was initiated. The benefit was consistent in patients with reduced ejection fraction or preserved ejection fraction, and it showed that this drug can be safely initiated in stabilized patients after acute decompensation. So to conclude, serendipity is perhaps to be credited with the story of SGLT-2 inhibitors in heart failure. They represent a new foundational therapy, a new roadmap for not only heart failure, reduced ejection fraction, but also in-hospital initiation can be considered, and now it is, of course, can be considered in patients with preserved ejection fraction as well. And now, of course, the new paradigm is evolving from the chronological stepwise order of initiating these drugs to rapidly sequencing them to quadruple therapy. And if you combine all these four, the fantastic four, you'll get the maximum benefit. And as summarized by Packer recently, rapid sequencing is a good thing. Beta blocker plus SGLT-2 inhibitor as a first step, followed by ARNI, followed by MRA. Of course, you can switch these drugs in whatever way you want, depending on the patient profile, but this is the best possible way. And all three steps may be achieved within 4 weeks, and slowly the drugs can be up-titrated later. Advantages are single dose, single OD dose, up-titration is better, renal function you don't have to bother too much. And as I say, the last slide, the story continues to unfold. At this time, there is a lot of momentum for using these drugs, and we as cardiology community should come forward as an important stakeholder in using these drugs in the entire spectrum of heart failure. Thank you.
Nice presentation, Dr. Aditya. Dr. Aditya, what has been your practice in using these SGLT-2 inhibitors, Dappa versus EMPA? Which molecule you are using more?
Sir, as I mentioned, we are using both. When the Dappa Hf trial was published, there was a lot of hype about the fact that Dappa Hf is the one which is associated with mortality benefit. But when you actually look at the published literature, it is probably because the EMPA HF or the Emperor reduced had sicker group of patients. Their ejection fraction was lower, their eGFR was less. So I personally believe it's a class effect. So we use both. And we haven't started actually in-hospital initiation. Dr. Rajiv is there, and I think senior people are there. They can offer their own perspective. We are not using in-hospital patients, and I have actually not tried it in preserved ejection fraction as well, but I'm sure it's a good drug to use.
Thank you, Professor Kapoor. I do understand that the data is too robust and recommendation is very strong. There's no doubt in that. And as I started your introduction, of course you veni, liberators and vidi. You came, you presented and conquered. All I want to ask you is, if we look at the principles of management of chronic systolic heart failure with reduced EF, the principles are basically confined to the two aspects. One is improvement of the failing myocardium. Second is targeting the compensatory mechanism in the form of either preload or afterload or whatever you call it. What I fail to understand is, how do these drugs help in diabetics as well as non-diabetics? Are the mechanisms different in diabetic population and non-diabetic population? And if they are used in non-diabetic population, why should they help? If they are helping in diabetic population with some sort of mechanism, how come that same mechanism is operational in non-diabetic population and non-diabetic population as well, at the cost of not affecting the glucose levels?
Sir, I'll briefly answer, then I think I'll tell Dr. Rajiv also to give his comments. Because you're right, people were wondering how do these drugs work. So there is absolutely no link with their reduction in HbA1c. There is no link with osmotic diuresis. Probably as Packer also said, they work metabolically. by shifting the glucose metabolism and by, the nutrition deprivation theory. There is a link now that they act by affecting the hematocrit, the uric acid. So how do they work? There are multiple mechanistic ways in which they work, but it is definitely not linked to their affecting HbA1c or osmotic diuresis at all.
Okay,
Dr.
that's
Rajiv?
the time that we have for this paper.
I think this is a common sense question and answers can't be precise also, but the excretion of the drug not only works on the SGLT-2 inhibitor, it also works on the sodium channel pump, which is very active. And if you permit me to speak, these are evolutionary gift of nature. If you see, the life migrated from sea to land, and there was abundance of salt which has suddenly disappeared in the periods of drought. So nature gifted us with three things: loop of Henle, SGLT2 receptors, channels, and sodium channels. And heart failure is perceived as hypoperfusion by the body, and they are upregulated. So if they are upregulated, they are downregulated by these drugs, and the glucose load decides about the excretion of glucose. And this is one of the mechanisms: ectopic, let me say, ketogenesis, ectopic adipose tissue reduction, then improvement in hematocrit. There are n number of mechanisms, and when there are n number of mechanisms, probably we don't know the mechanism.
I'm extremely sorry, Mr. Chairman.
We
have
can
to
take
open
one
our
query
program.
from Dr. Sudeep.
We'll have,
Dr. Sudeep, please.
I have an issue with that slide of that Packer, because that has downgraded the MRA. And we know that the mortality reduction is maximum with the MRA, followed by the beta blocker, followed by the ARNI, followed by the ACE inhibitor. And in that article, if you see that he has written there is a conflict of interest because he received funds from the SGLT2. I really, because common message is going to the public that you start SGLT2 inhibitors and leave behind the MRA. Because
No,
that
Padmanabhan, I'll just take 30 seconds to respond. So we have to take his permission. So in that article also, Packer clearly says that he is not trying to although you are right that he has moved SGLT2 inhibitors above, but he says that patients of heart failure are often hypotensive and they have, dodgy renal parameters. So that is why SGLT2 inhibitor and beta blocker can be started prior to MRA, but if these two parameters are okay, and you want to start an MRA first, then you are you can do that as well. Although in that guidelines he says SGLT2 inhibitors and beta blocker first, followed by MRA at step 3. But he says you can, go up and down the sequence.
Okay,
As
we'll
many
have
as
to
possible on
move
day one. As many as possible on day one, always underdose them, because all of them you can't have at target dose.
that-
So it is more important to have 4 mechanisms being attacked rather than one and up titrated, what Naveen showed.
That's all the time that we